Okay, team, let's move on to adjunct agents. So we are going to talk about a couple different types. Under antidepressants, we will talk about SNRIs and TCA antidepressants. If you remember, these are amongst the first line therapies for neuropathic pain. We then have anticonvulsants. Primarily, we're going to talk about gabapentin and pregabalin. Muscle relaxers, we have several different agents we can speak to. Local anesthetics and analgesics, primarily going to be capsaicin and lidocaine. And then finally, ketamine. Just remember, ketamine kind of falls in the ICU, big traumas kind of situations. So let's start out with the mechanism of action of tricyclic antidepressants. Unlike what we've talked about previously, you guys have not got pharmacology about this, so I just want to give you guys an overview. So you can think about these as inhibiting the reuptake of norepinephrine and serotonin, which can kind of tell you a little bit about the side effects. You do worry about things like MAOI inhibitors because it can increase your risk for serotonin syndrome. Any agent that has serotonergic effects, that's really where you will see. So if you think serotonin effects, avoid MAOIs, and you have an increased risk for serotonin syndrome. Norepinephrine is kind of like our fight or flight neurotransmitter. So that's one of the reasons why you see things like tachycardia down here. Also, a lot of the agents that affect serotonin and norepinephrine will increase your seizure risk. We'll also see this whenever we talk about some opioids as well. So, big side effects here are anticholinergic, and I do need you to remember that because TC antidepressants are associated with anticholinergic effects. The agent that we're going to talk about later in the skeletal muscle relaxants, cyclobenzaprine, is also a TCA or a TCA-like, and it has anticholinergic side effects. It can cause QTC prolongation as well. I'm not going to have you guys know about specific agents just because you guys are going to learn about that in neuropsych. It is a first-line agent for neuropathic pain. It can be used as adjunct agents in fibromyalgia and migraine therapies. But that's beyond today. Contraindication, as I mentioned, serotonin syndrome, and then also QTC prolongation is also listed down here as one of the drug interactions. You do not want to use it after the recovery phase after an MI because of its increased risk of MI and stroke. Its anticholinergic effects makes it a Beer's drug. And then if you have a history of a seizure disorder, because it can decrease your seizure threshold, it is one of those drugs that you would want to avoid. Again, here are your drugs. You will see that some of these we maybe have talked about before, whether it be nortriptyline or amitriptyline whenever we talked about IBS syndromes. But again, these are just FYI. Serotonin norepinephrine reuptake inhibitor. They work slightly different than TCAs. As you can see here, TCAs inhibit the reuptake of serotonin and norepinephrine, but it's not through the same effects. So it's kind of a separate class here. And it primarily works on serotonin with some norepinephrine effects as well. But you can see here that you have hypertension, you have gyromouth anorexia, and erectile dysfunction. These are actually also common side effects as SSRIs. So they kind of fall into that same category. You have an increased risk for bleeding, and they can be hepatotoxic. And I misspelled hepatotoxic. And we can add a very sad liver here. That's my best sound. May be beneficial in patients with mental health diagnoses, and it does have similar dosing, and it is a first-line neuropathic pain agent. Now, we do have multiple agents that are first-line in neuropathic pain. Usually the decision about which one that you would use would be based off side effects, as I mentioned before. As of its serotonergic effects, you do have MAOIs as a side effect. And it does have Beers criteria just because of the blood pressure increases and orthostatic hypotension associated with it. You can see here that its drug effects are primarily with serotonergic agents. It doesn't have the QTC prolongation that you see with TCAs. Remember, duloxetine is in the lower back pain guidelines, so that would be an agent that you could use. Overall, okay, our next group is the anticonvulsants. These are structurally related to gabapentin, and we're going to talk about gabapentin and pregabalin. There are other anticonvulsants, obviously, but these are the two that you would see the most for neuropathic pain, and they're both first-line agents. The only type of neuropathic pain that you might see different ones for is the trigeminal neuralgias, where you do use carbamazepine as a first-line agent. They're structurally related to GABA, and they work on one of the subunits related to GABA. So you can think of these as kind of like GABA works, and they do both have GABA in them, so that really does help. There we go, GABA. Side effects: ataxia, dizziness, drowsiness, fatigue. You can have potential withdrawal or euphoria. The euphoria doesn't occur whenever you withdraw. It is a controlled substance because of these euphoria and also the risk of dependence. It is used in neuropathic pain. It is a first-line treatment for neuropathic pain. It has contraindications related to hypersensitivity to gabapentin and pregabalin. You can notice that they usually have very similar side effects, but you do have a precaution for angioedema in pregabalin and sudden cardiac death in gabapentin. So make sure that you do know these. As far as you just need to know those side effects, as far as taking care of patients, it usually doesn't come in mind really, unless you do have a patient that has a side effect of angioedema with pregabalin. Drug interactions are primarily other CNS depressants, just trying to make sure that you don't oversedate your patient. Skeletal muscle relaxers. Skeletal muscle relaxers can be defined as antispasticity or antispasmodic. There are agents that are both. The ones that I highlighted here with the black underline are the ones that we're going to talk about today and are the key ones. Dantrolene is primarily used for malignant syndrome and has a lot of hepatotoxicity, so it's primarily not used for pain management. Antispasticity help with muscle tone and stiffness. You can see baclofen used in spinal processes, and you can kind of think of it that way. Antispasmodic decrease muscle spasms, so spasmodic spasms. And you can see here that the majority of these agents fall into that. Tizanidine is both antispastic and antispasmodic. I will say that as far as pain management goes, probably the agents with the best evidence behind them as far as treatment of pain would be cyclobenzaprine and methocarbamol. You can see that all these drugs are on your top drugs list. Side effect or agent wise, you have a couple agents that do work primarily on GABA, baclofen, and cardisoprolol. Methocarbamol just is a general CNS depressant, and it's not really known how it works, kind of like scalaxin down here. Cyclobenzaprine is related to a TCA antidepressant, so this is the one that you can kind of think of as TCA-like, and its side effects will be very similar. You can kind of remember that because tricyclic antidepressant and cyclobenzaprine. And then tizanidine. Tizanidine is a central acting alpha-2 agonist. Clonidine, a blood pressure medicine, is also central acting alpha-2 agonist. So you can imagine that their side effects are very similar. So looking here, like this tizanidine, the mechanism of actions help us with our side effects, with the tizanidine causing hypotension and bradycardia, cyclobenzaprine having things like dry mouth and overall anticholinergic effects because it has that TCA effects. Um, the rest of these primarily have things related to general CNS depression, things like increased risk for seizure for methylcarbamol, um, drowsiness and dizziness, things like that for scalaxin. And then baclofen, you do have to worry about withdrawal syndrome. You always titrate down baclofen. And that is a box warning. You can see here, as far as contraindications and precautions, both baclofen and methylcarbamol should be avoided in seizure disorders. Baclofen should be avoided in patients with psych diseases, related to the GABA action primarily. Cardisoprolol does have a control for substance abuse, or is a control for substance, so it is considered having abuse potential. It doesn't really have any seizure risk or anything like that. Um, Cyclobenzaprine, it does have those serotonergic agents or serotonergic effects, and has that drug interaction with anticholinergics like TCAs. You do want to avoid them in heart failure and arrhythmias because of the tachycardia associated with them, thus TCAs. Interesting enough, you do have interactions with Cipro and fluvoxamine due to CYP1A2 interactions with tizanidine. It actually will increase the risk or increase the concentrations of tizanidine and cause bradycardia and hypotension. So just overall, what we need to know. Baclofen, think spinal. Baclofen, think spinal, spasticity, and worry about the withdrawal syndrome. You don't want to use it in psych or seizures. Methylcarbamol, similarly, you don't want to use it in seizures. It is a spastic agent, spasm agent. Cardisoprolol is a control 4 substance and mostly just has general CNS depressant. It is a GABA agent, so that makes sense. Cyclobenzaprine, TCA-like, so you are going to see those anticholinergic side effects. Can't see, can't pee, can't spit, can't go to the bathroom. Metaloxone or scalaxin. You do have this risk for hemolytic anemia, but primarily it is generally better tolerated than a lot of the other ones, but it does have its general CNS depression that you have to worry about. And tizanidine, keep in mind that hypotension and bradycardia and the CYP2A interaction. And then, local anesthetics. So example here is lidocaine. Lidocaine is something that we can use as an injection, especially for local site pain. So for example, many of you guys probably have seen Dr. Pimple Popper. They usually inject those spots with lidocaine before they use it. It also has a patch form that we use. Dosing will be route dependent. And for the patch and the topical agents, you do want to avoid them in traumatized mucosas and bacterial infections. Side effects, especially whenever you inject them, include bradycardia and circulatory shock. Otherwise, most of them are local in factor. The patches are second line in neuropathic pain, and the patch is relatively well tolerated. We do use it sometimes in acute pain in the hospital. Capsaicin, the reason it has a nice little pepper here is because it actually is a derivative of peppers. And you can kind of remember that way. It's mostly like a counter irritant, like the spiciness of the solution makes you feel that as opposed to your pain. But it has been associated with better pain management. It comes in a cream and 2 different types of patches, and those patches do have different dosing, so just keep that in mind. Biggest side effects are local. It is a second line agent. It is over the counter. It can be used as an adjunct in acute pain, so that's one of the reasons why we have it listed in the acute pain side. So just keep that in mind. You do not want to cover it with bandages or use it on broken skin. You do want to avoid contact with eyes, mouths, or genitals or any other mucous membranes because of the serious burns related to the application site. For that reason, you primarily use it on your hands and knees. And then finally, ketamine. So ketamine for a long time was a illicit substance. It was known as Special K. I always do the same joke, which is that was also my nickname in high school. It is a NMDA receptor antagonist and blocks glutamate. So the reason that it was used as a illicit substance is that it is an hallucinogen. So you can see that in the side effects. So you can kind of think of like it's almost like an LSD. So anyway, you'll see that they can have confusion and delirium in a dreamlike state, hallucination, and vision imagery. So that's like that hallucinogenic effect. It can cause increased AST and ALT, sad liver, and causes blood pressure, pulse, and hypertonia. So increases in blood pressure and pulse is the big thing. Doesn't have any really contraindications as far as heart disease, though. Big contraindications are patients with schizophrenia. We don't want them to fall further into that hallucinatory path, and also patients with acute intoxication of alcohol. It's used primarily in hospitalized patients with acute pain, with increasing indications for chronic pain, as ketamine actually is used for depression. So that's also an agent, the way that we're using it. Drug interactions really involve CNS effects and CYP3A4 interactions, and it's typically used for our purposes in severe acute pain or refractory pain syndromes.